This is part 2 of the lecture on imaging of the eye and orbit. Let's move on to some true pathology of the eye itself. I will talk about herniations of the eye. We'll talk about detachments of various layers and corresponding hemorrhage, papilledema, which we can occasionally find, some calcifications, masses, and the effects of trauma, and then post-surgical findings. The differential diagnosis of staphyloma versus coloboma is something that radiologists love to talk about. I should tell you that clinicians do not consider this a useful differential diagnosis because these two diseases occur in entirely different patient populations. Staphyloma is a degenerative disease that occurs in the elderly, and coloboma is a congenital disease that occurs in children. So putting them on the same differential diagnosis is fun for radiologists, but not really clinically meaningful. A staphyloma is a broad-based abnormality of the posterior globe, whereas coloboma is a tiny defect in the posterior globe, and that narrow neck allows material to escape through into a dumbbell configuration. This is an example of a staphyloma. And it brings up a really important general point when we're imaging the globe. The globe is a sphere. If you ignore the anterior chamber, it should be perfectly round. We're going to keep coming back to that concept. Now look at the affected eye and look how elongated it is in the anterior posterior dimension. This is not shaped like a sphere. This is shaped like a grape. What has happened here is a failure of the posterior wall of the orbit. The whole thing has collapsed back just like a protrusion in the lumbar spine. You can imagine how this defect in the back would result in myopia, where the focal point of the lens is still way up here where the retina is supposed to be. That's a staphyloma. This is an example of a coloboma. Instead of the entire posterior wall of the globe being abnormal, instead there's a tiny little defect, and you can see that the vitreous humor has escaped through that defect and formed a second eye posteriorly in a dumbbell configuration. Sometimes colobomas will arise right at the optic disc. As in this case, you can see that small defect, somewhat larger than the last case, but a small defect bilateral at the level of the optic discs. When we talk about detaching different layers of the walls of the globe, usually it's because there's hemorrhage underneath. So talking about detachments is kind of the same as talking about hemorrhages into these different layers. So the three different layers that you can have detachments of are the hyaloid layer, the retinal layer, and the choroid layer. And we talk about these as subhyaloid hemorrhage, subretinal hemorrhage, and subchoroidal hemorrhage. Fortunately, these each have a different radiologic appearance. When you have subhyaloid hemorrhage, it is layered. It is heavier than the surrounding vitreous, and it is dependent with gravity, and you get a horizontal line. When you have retinal detachments, you can't make that horizontal line because the retina is tethered, is permanently tethered at the optic disc. You can't separate the retina at that point, and so it becomes the point of a V-shaped hemorrhage. The choroid is very difficult to separate, and so it requires a lot of force, and so the hemorrhages that separate the choroid tend to be rounded, focal, fist-like areas of hemorrhage, little round balls of clot, and that's what they look like radiologically. Here's an example of a subhyaloid hemorrhage. Notice that there is a perfectly horizontal line, and there is layering blood in the back of the globe. This is the expected appearance. It's just gravity. If you turn this patient, this will shift into a new configuration, but always horizontal with gravity. This is the configuration we expect in a subretinal hemorrhage or retinal detachment. Notice the V-shaped configuration. One straight line here, one straight line there. This is the retina being separated away, but you can't separate it away at the optic disc. It's tethered there, and thus you get that V-shaped configuration for a retinal detachment. This is the example of a subchoroidal hemorrhage, rounded ball-like areas of clot at the periphery of the globe. This is pretty rare. Often you get combined hemorrhage. There's a subhyaloid horizontal line here. There's more of a V-shaped look to this part, and then there's this little ball-like area. So probably all three layers detached from one another in this example. You can even pick these up sort of incidentally on other imaging. This is obviously an MRI of the brain where we can barely even see the globe, but look at that. There's that V-shaped configuration coming to a point at the optic disc. That is a retinal detachment, probably a chronic retinal detachment. That's why it's no longer a straight line. It's got that wavy appearance as the clot slowly resorbs. There is one way to get subretinal hemorrhage that is not direct trauma to the eye. If you have subarachnoid hemorrhage in the intracranial vault, it can track along the CSF, along the optic nerve. Right? This is continuous white matter, that's continuous CSF, and so the subarachnoid hemorrhage can just track along. It can then track directly into the globe. It's poorly understood how it jumps into the globe, but then it then tracks directly into the globe, and you can get a subhyaloid hemorrhage as a result of hemorrhage along the optic nerve from the intracranial vault. This is called Terson syndrome. We're not particularly good at identifying papilledema as radiologists. The fundoscopic examination is much more sensitive, but in extreme cases, you can actually see papilledema. Remember, we're going to keep coming back to this theme, remember that the globe should be a perfect circle, give or take the anterior chamber, a perfect circle, and this little bulge in the back, that's abnormal. That bulge is right at the optic disc, which lets us know that this is papilledema. Let's move on to calcifications of the eye itself. Probably the most common calcifications we encounter are degenerative calcifications at the insertion points of the extraocular muscles, so-called insertional calcifications. Drusen is another common form of calcification and is easily identified by its configuration and location. And then, less commonly, we can get dystrophic calcifications, which are the end stage of either infection or hemorrhage. Any insult to the eye can result in coarse dystrophic calcifications. This is what a drusen looks like. It is a punctate focus of calcification right in the center of the optic disc. That location is key. Also, the fact that it is a tiny, tiny calcification. Not all drusen calcify, so sometimes it is simply invisible to us radiologically, but when we see this, it's a characteristic appearance and you can be definitive about the diagnosis. Usually, these are not clinically relevant. This is what insertional calcifications look like. They're very common. You've seen these all the time on CTs of the head and orbits. At the point where any of the extraocular muscles attach, you can see these coarse calcifications along this circle called the arcus senilis, and these also usually have no clinical relevance. Here are coarse dystrophic calcifications that are a result of prior trauma to the eye, and they do result in at least partial blindness of that eye. Now let's talk about ocular masses. This is just a list of the masses that arise within the globe itself. I have to say they are all unusual to rare. No common entities here. Uveal melanoma is famous because of the intrinsic bright T1 signal that may be present in these lesions. Not all of these lesions are intrinsically bright on T1. This may be the result of intrinsic melanin or the result of microhemorrhages within the lesion. Here you can see on this unenhanced T1 weighted image, not even fat-satted, unenhanced image, you can see the bright object along the back of the globe. That is a small uveal melanoma. Of course, melanoma is also a very vascular lesion, and you can see them enhance on the post-contrast imaging as on the medial aspect of the right globe here. Retinoblastoma is famous because it has coarse calcifications in a characteristic location along the posterior globe. Although CT can be useful for establishing the diagnosis, MRI is preferable to establish the extent of disease and determine how extensive a resection is necessary. This is what a retinoblastoma looks like on MRI as an enhancing lesion in the posterior half of the globe. And you can tell that there's no extent beyond the globe on this image. Very useful. Persistent hypertrophic primary vitreous is a developmental abnormality of the eye. The key imaging finding here is a straight line connecting the optic disc forward to the center of the lens. If you can make out an object that runs that space, then you are probably seeing PHPV. Note also that the spherical configuration of the contralateral globe is distorted here on the affected side. There is a tug in on this posterior wall that turns it from a sphere into more of a pumpkin shape. That's also characteristic of PHPV. Often there is hemorrhage associated with PHPV, and it can be very difficult to identify that line connecting the optic disc to the lens. But if you look carefully, even underneath all of this hemorrhage, there's still that straight line there, and maybe less evident on this side, but there. And look again, that pumpkin configuration is another clue. I'll quickly mention Coates disease. In this abnormality, you see thickening of the posterior wall of the globe, and you can see hyperdense material within the vitreous chamber. This is not a radiologic diagnosis, though. Metastatic disease normally affects the orbit or the bones surrounding the orbit and rarely affects the globe itself. When you do get a metastasis to the globe, there is replacement of the normal vitreous fluid with enhancing tissue, as you can see here, just a tiny little sliver of vitreous left behind. The other clue in this case is that the other eye has already been resected for metastatic disease. This is the end of part 2 of the lecture on imaging of the eye in orbit.